Good morning, everyone. We are continuing with our videos. This time, it's Deb. My Karen is not with me at this moment for this video, so you'll have to put up with me. So I want to talk about closed chest drains, and we talked about the PleurX the other day. So I want to talk a little bit about the difference between the two. Both of these are used for pleural effusions, which means that there's fluid in between the lining of the chest and the lung. So it gets encapsulated, and what that will do is put pressure on the lung, and it will create shortness of breath. Sometimes it can kind of collapse the lung a little bit even. So you want to be aware of that, and you want to take care of things to help to alleviate that as much as possible. So, monitoring lung sounds, monitoring oxygen saturations. If you're getting labs, if they happen to be doing blood gases, paying attention to those. Are they on any sort of oxygen support? You definitely want to be thinking about those sorts of things, most definitely. So, the PleurX drain is usually more for the home setting. It is intermittent. It's intermittent draining of the fluid. So usually the patient they can go up to 3 days, even a week, without having the PleurX drain drained. Usually if it's more than that, the doctor's going to be considering taking the drain out. So the PleurX drain we went through the other day. I just wanted to readdress that again. And then today, I want to talk about the closed chest tube, that setup, having a chest tube hooked up to suction. So this is for acute and continuous use. So it's not intermittent like the PleurX drain. So it'll come in a package. This is all sterile inside. You don't necessarily have to be sterile to open this up. You can be clean, but you do need to pay attention. There are some sites on this container that you need to make certain that you keep sterile. So it comes in a box like this. So let's go ahead and remove this. Let's get this out of the way. Sorry, limited space. So this is what the closed chest drainage tube system looks like. So, oops, let me put that back there. So initially, the very first important thing that you need to do is, as you can tell, this is pretty thin and it's pretty unstable if it's just standing on its own. So there is a little foot that's here on the bottom. It pivots. This little bar pivots and locks into place. I highly recommend, if you want to be in good favor with your peers, you put this foot down first, because let me tell you, if this tips over, all the drainage in this area where it gets collected starts flowing into the other chambers. And when you're trying to keep outputs on how much drainage is coming out, with you, usually it's recorded every shift. If you're trying to keep those output amounts, you have to count in every 3 chambers. And then your coworkers that follow you have to do the same. And it is a huge pain. Oftentimes we will just switch out the system if it's fairly full, because it just becomes confusing and you aren't able to keep track in a real accurate way. So this is the closed chest tube drainage system. Flip the foot at the bottom. Now I'm just going to go through the different parts and pieces. So this is set up, it's with water seal suction is what it's called. What that means is there's a little container that has water in it. It's a little ampule. And there is a little hole right here, this little blue hole up here at the top. You twist off the cap, you turn this upside down, and you squeeze all that fluid into this port right here. What that does is it comes down in here into this chamber. I'll try and get it so you can see it. Comes down into this chamber. It will turn blue so that you can see what that water is doing. So in this chamber, as it creates water seal suction, what you want to monitor in this chamber is there bubbling in there? If there is a leak in the chest tube, it will bubble in this area. If it's staying pretty constant, then everything's okay. Your suction is good. So you definitely want to pay attention to that. This little piece right here, you can see there are some numbers there. There is a little, back here in the back, it looks like a little water wheel. This turns. This helps to dial in the suction amount. So the doctor, usually kind of as a general rule, the doctor will say that like the setting at -20. So you can see right there, it says -20, and I'm almost there. So there, that dials it in at -20 millimeters per mercury of pressure. So that is extremely important. There is a, where's my other, I'm looking for my suction setup. There is a place. I'm used, and the other system that I used to using is there's another hole where you hook suction up, but it very well could be that it goes, excuse me, it says suction right there. Okay, this is a newer device for me. After you have put the water in here, then your suction will go on here. Your wall suction will hook up to that. So you will hook that up, and you basically want to increase the pressure so that you can see in this little window right here, there will be a little orange pillow that will float. And so you want to dial in your mount, have it hooked up to suction, dial in your mount, and then watch for this little orange pillow to float in this window. When the pillow is floating, that tells you that you have suction and that everything's working okay. So that is another area you want to pay attention to. Are you getting bubbling down here in the blue water? And does that mean that there's a leak? Is this floating, which shows that you are getting accurate pressure? So, sorry about that. Nothing like a new system, right? So, moving right along. In the back here, you will find this tubing right here in this little envelope. Right back here. So you pull this out, and then what you want to do is you need to make certain that you are not touching the end of this, because this is where the chest tube will attach to your tubing. Now then, and so you want to make certain that those are sterile connections between the chest tube and this tube. Now then, there is a clamp here. You usually do not want to put the clamp on because that will create pressure inside the lungs. The time that you would put a clamp on is if you're changing out this unit. So just be aware there's a clamp here, but it really should stay in the open position. Now then, depending on where you work or what if the patient has come from the hospital, which usually is what happens, they probably have really taped, helped tape the bejiggers of the chest tube and the suction to make certain that it doesn't pull apart. Some things to watch for. You need to pay attention to your patient's lung sounds. You need to monitor the oxygen saturations, most definitely. You need to check for air leaks. You need to then also check for COCA. So color, amount, and drainage. You look in these chambers to see what that looks like. Now then initially you'll probably get a lot of bloody drainage or serosanguinous drainage. But as this tube is in there, more and more, usually it turns to a more serous drainage. So you want to pay attention to that. And you'll see there are graduating lines and everything, so you can mark the amount that is in there. So it also does have some cheat sheet directions back here, which is great. Especially if you haven't had a chance to use one of these for a while and you are just getting a patient admitting into your facility or wherever you're working that has one of these. So usually the doctor will give you parameters so that you know exactly what you're supposed to be doing. And you'll want to also monitor the patient's level of pain, because this can kind of be uncomfortable, as you can imagine, having this tube in their chest and hooked up to suction. The tube is probably about that big. So I have a little story from my experience as a nurse. It was when I first became an ICU nurse. And we had a very young lady in the unit who, she was in her 30s, not very old at all, very, very sick. We were doing peritoneal dialysis on her. And she also developed a collapsed lung. And so the doctor, it was a resident, the resident came in and put a chest tube in. And we did a repeat chest x-ray just to take a look and see how everything looked for placement and all, and it seemed to be okay. They just did a single view, so it was just from one angle. Anyhow, I was doing things in her room, and all of a sudden I noticed this white curly matter coming down the chest tube, and I thought, well, now that's really weird. And I thought, oh my goodness, does she like have worms, or what's going on? So I quickly called the resident, and the resident came back and assessed things. And I suddenly became very aware she was lopsided. The resident had accidentally punctured her breast implant, and it was coming down the chest tube. So needless to say, the hospital had a little bit of replacing to do there, but that always made an impression on me. It was like one of my first chest tubes, and it was a bit startling, most definitely. It was not what I had been expecting to see for chest drainage. So anyhow, beware, pay attention to your drainage, pay attention to your equipment, and make certain that everything is functioning okay, and that the patient is doing okay with what's going on. So I think that's it for now. Thank you so much. Have a good day. Bye for now. Okay, I'm having a tough time finding my stop button. Oh. Okay, where's the stop record button? All right. Are you still here? Go wash your hands.